am talking to you from Oslo, Norway. First of all, I want to thank the organizer for making this Congress possible virtually, in spite of these different and difficult times. And I also want to thank them for that we can have a teaching course on this very important topic about the sleep side of neurological disorders. And my talk will be about parasomnias and sleep in neurodegenerative disorders, with a specific focus on early disease prediction and detection. So here are my conflicts of interest. I'm sure that most of you are very familiar with the phenotype and symptoms of neurodegenerative disorders in general, but those are probably mostly the symptoms that occur during the daytime. We're going to focus much more on the night and sleep side of the neurodegenerative disorders. And so I'm just going to give a little brush up on the sleep world to you first, before I fill in with some more advanced details. First of all, we're going to talk about parasomnias. So I'll just quickly rebrush what parasomnia is. A parasomnia is a neurological disorder caused by a brain dysfunction. They are characterized by abnormal behaviors and experiences and autonomic responses during sleep or emerging from sleep. Parasomnias are dissociative states, so they consist of an abnormal mixture of features from both sleep and wake, or different sleep stages. They're characterized by the sleep stage they emerged from. If you can see in that book in the top of the slide, the International Classification of Sleep Disorders, they're classified in rapid eye movement sleep or REM sleep parasomnias. For example, REM sleep behavior disorder, which we're going to hear a lot about in this talk. And also in the non-REM sleep parasomnias, for example, sleepwalking. And then the state-independent parasomnias that have features from both REM and non-REM, also called overlap parasomnia disorders. I'm also just going to give you a little upbrush on the way that sleep and wake is characterized in the normal brain and in normal persons before we go on to how it is abnormal. Sleep and wake are characterized by stages that you can see here on the left side of the slide. These stages can be viewed on EEG. And on the right side of the slide, you can see that we sleep in a certain pattern. So these stages are organized in a certain pattern during the night. When we are awake and fall asleep, we go through stage 1, light sleep, and then deeper and deeper down to deep sleep in stage 3, non-REM sleep. And then we go, after some time in stage 3 sleep, we go up to REM sleep, which is a more active sleep stage. And then we go through these circles through the night, through light sleep, to deeper sleep, to REM sleep, to deep sleep, to REM sleep. And as you can also see on the hypnogram, there's most REM sleep in the end of the night and most non-REM and deep sleep in the beginning of the night. And this is a clue onto where some of these diseases that arise from specific sleep stages, when they will occur during the night. For example, REM sleep behavior disorder, which we're going to hear much more about, most often occur when there's most REM sleep, which is mostly in the end of the night. But you can also see that on the EEG that wake, the EEG is more desynchronized. There's a lot of activity. And this is also corresponding to that you are normally, when you're awake, conscious and you can move and you have no dreaming. But REM sleep, that is also the dream stage, looks a lot like wakefulness, on the EEG anyway, because the EEG is desynchronized. But at the same time, you are not conscious, you are unconscious, you cannot move because you're paralyzed, and you dream. So it is different from wake in the way you behave, but the EEG looks a lot the same. In non-REM sleep, the EEG is increasingly synchronized, but you are, just as in REM sleep, unconscious, but you can move and you can dream. Now we're going to talk a little more about the basics of regulation of sleep and wakefulness. First of all, as you can see here in the picture, these processes are regulated by the brain. On the left side, you can see the reticulary ascending activating system. This is the system that keeps us awake or wakes us up. The nuclei in this system are located in the brainstem and in the midbrain, and through an active process, they activate the cortex, and in that way we are woken up or kept awake. But on the right side, you can see that there's also a descending inhibiting system. And that is the system that either initiates sleep or keeps us sleeping. This system inhibits the ascending activating system. So in that way, wakefulness ends. But it's important to realize that the inhibiting system, or the sleep system as you could call it, initiates or maintains sleep in an active way. So both sleep and wakefulness are active brain processes in that way. The reason that I emphasize this is that if you have brain activities that should work both during the day and during the night, then if something goes wrong, if you get a neurological disorder, for example, you should also expect that there can be loss of function both during the day and during the night. So there can be daytime and nighttime systems in many neurological disorders. I'll come back to why this is especially important when we focus on the neurodegenerative disorders, that you realize that you should look for both the daytime symptoms but also the nighttime symptoms of these disorders. Sleep and wake are regulated, as I said, by nuclei in the brainstem and the midbrain, but these mutually inhibit each other or exclude each other. That's how it is normally anyway. So here you see this way it's organized via a neuronal flip-flop switch system where you are either awake or asleep. The system is regulated by hypothalamus, by the orexin system or the hypocretin system, which is located in the hypothalamus. And if there's a normal neuronal flip-flop regulation, this system ensures that we are mostly either asleep or either awake. And when we are awake or we are asleep, then we have intact tonus regulation during wake and non-REM sleep, but we are atonic or paralyzed during REM sleep. It ensures that there's not so much in between states, that we are not so much partly awake, partly asleep, and we don't have dissociated tonus or REM symptoms at times where they shouldn't be, for example, during wakefulness, if it works. But then sleep also consists of REM and non-REM sleep, as we talked about previously. And this being in REM sleep or not, and the tonus regulation that is associated with REM sleep, that you are atonic when you are in REM sleep, this is also regulated by another neuronal flip-flop switch also located in the brainstem. This flip-flop switch consists of REM off neurons, the ones in red here, and REM on neurons, the ones that are in green. And these flip-flop nuclei also mutually inhibit each other, so they sort of exclude that you can be both in REM and non-REM sleep. From animal models, it's known that if you lesion the REM off nuclei, you get symptoms like cataplexy, which is that you're paralyzed or you have REM sleep paralysis when you are awake. And if you lesion the REM-on neurons, then you get more or less the opposite symptoms, that you can get RBD, or REM sleep behavior disorder, where you are in REM sleep, but you are not paralyzed. So from animal models, it is known that the hypocretin neurons are the main stabilizers also of this REM sleep flip-flop switch. So if this works normally, then hypocretin regulates both flip-flop switches so that REM and non-REM features do not occur at the same time, as I said. That REM sleep features like muscle atonia, dreaming, they occur not during wakefulness, for example. And when you are in REM sleep, you are paralyzed, so you cannot move and act out your dreams. So in that respect, parasomnias, as we talked about, that are dissociated diseases or dissociated states, they could be looked upon as sort of bad functioning neuronal flip-flop switches. Either because they are not well regulated, for example, by hypocretin, or maybe some side of the flip-flops is lesioned. Now, in a minute, I will show you why it's no wonder that parasomnias and sleep pathology is highly, highly prevalent in neurodegenerative disorders. Here again, I show you the location of the sleep and wake regulating nuclei in the brainstem and the midbrain here in humans. And here is a picture showing you the model of the Braak stages of, for example, Parkinson's disease, one of the major neurodegenerative disorders. And as you see, the neurodegeneration begins also in the brainstem and ascends up through the brainstem and the midbrain and further on to cortex. So in that way, at least in Parkinson's disease and in synucleinopathies, you can see that the neurodegeneration simply moves its way right through the sleep and wake regulating nuclei, or where they are located. So this is why that neurodegenerative disorders in a very high percentage have a sleep side or a sleep pathology side. That is one thing, but also that this sleep side or this sleep pathology often precedes the daytime or the more known side of these diseases. So it can predict what will happen because it's a very, very early sign to have specific sleep abnormalities. So the wake and the sleep side of neurodegenerative disorders. As we talked about, this gradual widespread neuronal loss that happens in the neurodegenerative disorders, it affects both neurons that are involved in the daytime and nighttime or sleep functions. So they can be lesioned and destroyed. But in addition, the neurons that are still surviving are also not functioning so well because there's abnormal protein deposits or accumulation in these neurons, alpha-synuclein, tau, beta-amyloid, and the ataxins. So not surprisingly, the symptoms and signs of neurodegenerative disorders are occurring both during the daytime and wakefulness, and those are the ones that we doctors see. But we also have to look for the ones that occur during the nighttime and the sleep because they're there. The typical daytime symptoms you all know, those are dementia, Parkinsonism, muscle weakness, ataxia, cerebellar syndromes, dysautonomia, eye abnormalities, and chorea, for example. But the nighttime symptoms and the sleep disorders are equally common, and they may, as I said, be the first disease manifestation of the neurodegenerative disorder. So moving on to the night and sleep side of neurodegenerative disorders. Well, a clue is that although sleep normally is expected to be quiet and you lie still, in these disorders you should rather expect a lot of noise and moving around. Because the typical symptoms at nighttime or the sleep phenotypical features or disorders are problems with maintaining sleep, so that they have insomnia, they can't fall asleep or they wake up. They have problems maintaining wakefulness, so they sleep during the day and they have excessive daytime sleepiness, or sleep comes at a wrong time, maybe because there's also lesion of the suprachiasmatic nucleus, so they have circadian rhythm changes. And then, as we talked about before, there are the so-called parasomnias, the non-REM parasomnias, where, for example, confusional arousals and nocturnal wanderings can be prevalent, but especially the REM sleep parasomnias and REM sleep behavior disorder and nocturnal hallucinations are very prevalent. These can be confused with the other sleep disorders like periodic leg movements or restless legs that can look like RBD, BRBD mimics, and also central obstructive sleep apnea and nocturnal stridor can be pretty violent, and the patient can move violently in order to trying to breathe because of low oxygen, or they can be aroused and be confused, and it can look like a REM sleep behavior disorder. In addition, as the neurodegenerative diseases progress, more and more sleep and wake nuclei are being destroyed. Hence, in the end stage of certain diseases, for example, Parkinson's disease, there can be sleep disintegration. This means that the patient is asleep, but you cannot find out what sleep stage it is because everything is just mixed up. It doesn't look like any sleep stage, any specific sleep stage. This is something that has also been discussed, whether the sleep disintegration actually participates in further progression of neurodegeneration, sort of as a vicious circle, but I'll not go further into that because that's also some of the theory in a later talk about the amyloid diseases. Now I will go on to focus for more or less the rest of the talk on REM sleep behavior disorder. REM sleep behavior disorder is a disease, a neurological disease, where there's a history of repeated episode of dream enactment. What does that mean? It means that you can act out your dreams if you dream that you are in a boxing fight, as this person is, then you actually box also while you are dreaming because you're not paralyzed anymore. And that can, of course, be violent if you have nightmares, but not necessarily. It can also be that it's just smaller twitches, but in REM sleep, or it can be that people are vocalizing, singing, and laughing, and things like that. But it can often also be violent. Or at least that is what often brings the patients to the doctor. When you then do a video polysomnography, which you should do to diagnose this disease, then you can see that on the left side of this video polysomnography, you can see how REM sleep should look like. But on the right side, you can see that it is REM sleep with eye movements, and also the EEG looks like REM sleep. But the EMG on the bottom is not flat as it should be, because we should be atonic, but it's full of phasic activity. And sometimes tonic activity on the chin and the limb channels, and it is corresponding on the video to that the patient is moving out or acting out his or her dream. So this is how you diagnose the disorder. And just to show you what REM sleep behavior disorder looks like, and just a hint, the patient is in REM sleep for the entire video. REM sleep behavior disorder was identified or described as a human neurological disease in 1986 by Carlos Schenk and colleagues. It has actually been seen as an animal model in cats since, I think, the 1960s. But in humans, it was identified in the 80s, as I said. At that point, nobody really knew what it was, but now it is recognized that was called the idiopathic RBD or IRBD is actually now recognized as the earliest form of a synuclein brain disease, either Parkinson's disease, dementia of the Lewy body, or multiple system atrophy. It can also be secondary, for example, as part of narcolepsy and other diseases. And importantly, in most of these diseases, it does not progress to a synucleinopathy. And here you see some of the most updated results from several studies of RBD cohorts that have been followed for up to 14 or 15 years. And as you can see, as the time goes on, more and more of those so-called idiopathic RBD convert to a synucleinopathy. So after 14 years of follow-up, over 90% of them have converted into either Parkinson's disease, dementia of the Lewy body, or MSA. This is also why that the idiopathic name is often now replaced by isolated RBD, because idiopathic is not really suitable for the disease. So the disease model for REM sleep behavior disorder, or RBD, is, as we talked about previously, that if you lesion the superlateral dorsal nucleus, you know, the little green one with an X over here on the picture, then you are in REM sleep, but you are no longer paralyzed. And this is what the theory is, that because of synuclein deposits and neurodegeneration at early stages of a synucleinopathy, this nucleus is lesioned, so the patients very early on have REM sleep behavior disorder before all of the other symptoms. So for a long time, they only have isolated RBD, but then at some point they have RBD with some symptoms, but not enough to call it an overt synucleinopathy. But then as the neurodegeneration progresses, they progress into a full synucleinopathy. And these models are supported by several findings, pathology findings. Here, for example, SPECT findings, where you can see that there's reduced striatal dopamine transportation, both in RBD patients that only have RBD, REM sleep behavior disorder, more or less the same findings as you see in Parkinson's disease. Though in Parkinson's disease, you see a reduced dopamine transportation contralateral to the symptomatic body side, but in RBD, it's bilateral. But they have no Parkinsonistic symptoms at that point, the RBD patients. And if you do biopsies, here is a study from where you see biopsies from submandibular glands of Parkinson patients, and again isolated RBD patients. And in both of these biopsies, you see the same pathology findings, the same alpha-synuclein findings, where you have a lot of immunostaining in and along nerve fibers. Also in the isolated RBD patients, just as much as in the Parkinson patients. Again, pointing to that the pathology is the same. So isolated RBD, or the primary form of RBD, is not an innocent sleep abnormality. It is a serious disorder that is linked to the development of a future neurodegenerative disorder and most likely a synucleinopathy. It's important to realize that the patient at this point does not have any motor daytime problems or cognitive symptoms, or at least they don't feel it themselves. They can, if you test them, have some deficits, for example, hyposmia, depression, constipation, or decreased dopamine uptake on imaging, as we just saw. And if you test them cognitively, they can also have deficits. Because isolated or primary RBD is so predictive of a later synucleinopathy, it is the best known prodromal marker, for example, for Parkinson's disease, with a positive likelihood rate of 130, compared to the other known markers like depression, constipation, and hyposmia. RBD is also a unique marker for dementia classification. If you have RBD combined with mild cognitive impairments, and that is that you have more or less RBD plus, not yet an overt synucleinopathy, well, these findings together indicate that within 5 years, this patient will develop a synucleinopathy dementia, Parkinson's disease with dementia or dementia of the Lewy body, but it will not be Alzheimer's or frontotemporal dementia. Now moving on to the secondary RBD. This means that RBD comes either after other disease manifestations or after medication or drugs. So in the synucleinopathies, it means that the other symptoms have started before RBD. RBD can also be secondary to other autoimmune brain disorders like narcolepsy, and I'll talk a little more about that later, but also other diseases like autoimmune encephalitis, paraneoplastic syndromes, and also brainstem lesions, and not surprisingly. But RBD can also be secondary to drugs, especially antidepressants and lipophilic beta blockers. And in these cases, it has in some cases been believed that it was just a side effect, especially if the RBD stops when you stop the medication. But it has also been questioned whether it really means that the drugs have unmasked a latent neurodegenerative process, especially if the RBD doesn't go away after you stop the drugs. But I'll come into that a little more later. Now moving on to secondary RBD and sleep problems or disorders in the synucleinopathies. In MSA, RBD is almost obligatory. About 100% of the patients have RBD, either as a first symptom or it occurs after the remaining MSA symptoms. They also have other sleep problems like insomnia and excessive daytime sleepiness, and then also sleep apnea and stridor. Those highlighted in red are the ones that can be RBD mimics. In Parkinson's disease, about 50% either have or will develop RBD. Parkinson's patients have a lot of sleep and night problems in addition to RBD. And especially the ones highlighted in red, like nightmares, visual hallucinations, confusional awakenings, and sleep apnea and restless legs can also mimic RBD. In dementia of the Lewy body, RBD is also highly prevalent and often precedes the dementia symptoms. They have a lot of sleep problems like the Parkinson patients. Nocturnal hallucinations and confusional nocturnal wanderings can also mimic RBD. In the tauopathies, taken together, I will not go so much into those diseases because they are being detailed described in a later talk. I'll just say that RBD is there, but not very prevalent, both in Alzheimer's disease and in PSP. But it can be confused with especially confusional awakenings, wanderings, and agitation that can be RBD mimics. But it can, of course, also be RBD. It's just not so common. An important issue is that a lot of these elderly patients also use antidepressants. So either they are young or old and with or without a neurodegenerative disorder, antidepressants can be associated with RBD. It used to be called medication-induced RBD. And as we talked about before, there's been suspicions about that it could actually demask that the patient in reality will develop a neurodegenerative disorder. So there are signs too that this could be true because RBD patients on antidepressants actually, if you test them, have a lot of positive neurodegenerative markers. But on the other hand, they have a lower risk on converting into a real neurodegenerative disorder. So this is still debated. So as we talked about, RBD can also be secondary in other neurological disorders such as narcolepsy. However, narcolepsy, where the patients lack the neurons in the hypothalamus that produce hypocretin or orexin, the neuropeptides that regulate the flip-flop switches, RBD is more a sign of dysregulation of these flip-flops. So you see here that the patients with a low hypocretin measurements, they have more RBD symptoms and more muscle activations during REM sleep. But importantly, in narcolepsy, the patients do not progress further on to a synucleinopathy, which is important to tell the patient. So just to sum up some of the important red flags regarding RBD in neurodegenerative disorders. If the patient has MSA, then RBD is almost obligatory. So if you have a so-called MSA patient without RBD, you really should re-evaluate the diagnosis. If you have a patient with Parkinsonism with no RBD, this points more to Parkinson's disease than to MSA. If you have a patient with dementia and RBD, then RBD indicates that the patient will have a diagnosis of dementia of the Lewy body, but not Alzheimer's disease or frontotemporal dementia. So moving on to RBD management. Well, first of all, it's important to be really, really sure of the diagnosis, because this is a really serious disease or disease marker, and you can be sure that the patient will Google this. So really focus on the clinical history and do the video polysomnography, both to diagnose RBD, but also to rule out differential diagnoses. Then comes in many ways the difficult part, because you then have to inform the patient and the bed partner about the disease, and it has no cure. So you must focus on good medical care and follow-ups. And RBD has major quality of life burdens. First of all, both the patient and the bed partner can be hurt. There can be injuries. And there can also be marriage problems and lack of intimacy, because the patient may try to, for example, strangle and hit his wife during sleep. And that can bring a lot of shame and embarrassment and fear of harming others along with the physical problems. And both the patient and the spouse can worry about that RBD may be repressed anger issues toward the spouse that comes out during the sleep, which is of course not the case, but they can worry. So the quality of life is lower in patients with RBD, also in synucleinopathies, compared to those without. And then, of course, you have to also follow the patient up, because unfortunately the disease will progress. So although there's no cure, you still have to do something, especially about the safety. You have to talk to the patient and the bed partner about minimizing the risk of injury, perhaps sleeping in separate beds or bedrooms, putting the mattress on the floor, etc. And then also advise to avoid alcohol intake, because that can worsen or trigger RBD. If there's comorbid obstructive sleep apnea, you should consider to treat with CPAP, because that can improve RBD-like behaviors. And also, if you want to treat with clonazepam, I'll come back to that later, you also need to have the obstructive sleep apnea treated. And then psychological counseling and help is important, because the prevalence of insomnia, anxiety, and depression is high. Many RBD patients will need pharmacological treatment. It's important to tell the patient that although a treatment can milden the symptoms or remove the symptoms even, it doesn't stop the neurodegeneration. So first of all, look for that they are not already on drugs that can worsen RBD, for example, beta blockers or antidepressants. And if they are, try to stop them or find alternatives. There are no randomized controlled trials on RBD, but there's clinical experience. Clonazepam up to 2 milligrams is often efficient, but it can be difficult to treat if the patients already have cognitive or balance problems or untreated obstructive sleep apnea. So if they have that, an alternative is melatonin up to 12 milligrams at bedtime. But then another strategy is also that if they have other problems, for example, that they have RBD and hallucinations, then you try to find drugs that treat both these symptoms, or CPAP if they have both RBD and obstructive sleep apnea. And in the future, RBD, as I hope you have now acknowledged, would be a unique marker for future neuroprotective drug trials, but unfortunately, we don't have any of those yet. Yes, and with that, I'm going to finish this talk. I just wanted to show you some good reading suggestions. And thank you so much for listening and for staying awake. And I will be happy to take questions. Thank you. So, hello everyone. Thank you for listening to this first talk. We're now going to have a little intro after the talk because we had a little technical problems, but that has now been solved, I hope. I'm so happy to be with you all here virtually. My name is Stine Knudsen-Heyer, and I'm chairing the session. First of all, I want to also thank you, the organizers, for letting us have this teaching course, but first of all, to actually hold the Congress virtually in spite of these very, very difficult times. So I think we should all acknowledge that they've been working really hard on doing this. This teaching course is called Neurology by Night. You probably already know. And we hope that what you will get out of this course is to see and learn about that neurological disorders have a daytime side, which you probably already know because those are the symptoms that are usually referred to as the neurological symptoms, but that they also, most of them have a night and sleep side. Sleep pathology is often part of most neurological disorders, but often unrecognized. And of course, if it's not recognized, then it's not treated. And some of these symptoms are really dangerous. So it's important to be aware of. The theme of this teaching course is also how sleep features can improve detection, prevention, and also potentially repair a neurological diagnosis. So we will have some really good talks about that. I hope that you enjoyed the first talk about prediction of neurodegenerative disorders by mostly REM sleep behavior disorder. But we will soon go on to the next talk, which will be about sleep, so the breathing in neurovascular disorders, both primary and secondary stroke prevention, which will be given by Dr. Evelina Pajadiene from Lithuania. And then we will go on to hear a talk about excessive daytime sleepiness and daytime falls. What is what? It is a video session on differential neurological features and signs that will be given by Dr. Fabio Pizza from Bologna in Italy. And then lastly, there will be a talk about repairing the brain during sleep, sleep-related features of cerebral amyloid accumulation disorders, which will be given by Dr. Rolf Fonsek from Leiden, the Netherlands. Just to tell you a little about how this live session or live teaching course is logistically. It will be that after each talk, there will be possibilities to ask and answer questions. And then the new talk will come on. And then again, just as if we were physically together, there will again be possibilities to ask questions and get answers. If you have questions afterwards that you didn't get to ask, then you can also, there's also a possibility to write questions during the talks. And if the speakers aren't available or if we don't have time, then we will answer the questions afterwards. Then I also was asked from the EAN organization to tell you that we really want you to evaluate this sleeping course session. And what you do is that you, below the live stream, next to the question and answer button, the Q&A button, you can. There's a button to click where you can evaluate the session. So we hope you will do that too. But because the introduction was now after the first talk, then there's actually time for some questions, if there are any, to the first talk. There are also some live questions. But possibilities for live questions. But actually, there was only a comment that said that it was a really great talk. So thank you very much for that. If there are no questions for the first talk, then I just had one comment, and that was that if you saw the video, at least I couldn't hear any sound during the video. But I just wanted to make sure that you knew that the patient moving around was actually in REM sleep the entire video. So it was a video I borrowed from Carlos Schenk that identified the first REM sleep behavior disorder patient, and actually it was a video of that person, so the patient. So, but just as you knew that he did not wake up, it was all during REM sleep that he was boxing and hitting the mattress. Okay, but if there are no further questions, oh wait a second, now there are. And there's a question about from Fernando G, and he said there's an oh, wait a second. An ethical issue. Do you tell a patient with an RBD diagnosis and no other neurological diseases about the possibility of a neurodegenerative disease? The question to that is yes. It is, of course, difficult because, as I said, there is no cure. But the patient will anyway, for sure, Google the diagnosis, and then they will be really scared and don't know that you can actually get help, at least for follow-ups, and you can also get counseling. So it is difficult, but it is like the other neurological disorders. Previously, if like 30-40 years ago, you didn't tell a patient that they had symptoms of MS, but then the patient probably didn't worry, but still had the symptoms and didn't know what it was. So yes, it is in the guidelines that you tell the patients about it, but of course carefully. And let me see again. Oh, there's a question about whether it's specific antidepressants that can induce RBD. And yes, especially the SSRIs and the SNRIs and the TCAs are known to be sort of RBD inducing. So you can change to some, if you need to still treat the patient for depression, you could consider to change to the options that I also had in the talk, bupropion, for example. But of course, it's not always possible. You can. The best thing would be to try to stop the medication and try something else. But of course, it's not always possible. And then maybe you have to treat with clonazepam on top, or melatonin. I think that were the questions that came through. So, and if I missed some, then we will answer them after or during the session. So I think for the sake of time, we will go on to the next talk, which is given by Dr. Evelina Pajene from Lithuania about sleep disorder breathing. Thank you.